Okay. Sorry, let me share screen. Okay, sorry about that, guys. I was brain dead when I explained this. So this is, so again, sorry for the resolution, but remember that in a glucose stimulated state, so the point of the sulfonylureas, got it right, is we want to target what beta cells there are around to stimulate insulin release. Okay, that's why we can't use these on people that don't have beta cell function. So what we want to do is mimic glucose without having glucose, so to speak. So the compounds do this by short-circuiting and stimulating the high glucose state. Okay, where do we go? I lost my slides here. So glucose, if you remember, drives up ATP, and ATP will then open this channel or modulate this channel, which will then depolarize, drive in potassium and depolarize the membrane. What the sulfonylureas are going to do is block open this channel. Okay, they pry it open by binding to the ATP binding site. So they compete with ATP, but they compete in a way that keeps the channel open. And this then artificially causes production and release of insulin granules. Okay, I said it backwards the other way last time. So the primary mechanism of action is to stimulate endogenous insulin release, binds to the ATP-sensitive potassium channel, and to mimic ATP, and then this sends to causes this to sensitize the beta cells more to glucose. It then will decrease lipolysis peripherally and decrease clearance of insulin by the liver, which facilitates again to raise our insulin levels, which is important, obviously, if you're type 2 diabetic and you can't produce insulin or have very low levels of insulin. Now, as I mentioned, these sulfonylureas only work in type 2 diabetic patients only. And typically, the ideal patient are those patients in the first 10 years of diagnosis, mainly because they still have beta cells. They haven't had beta cell exhaustion, and they can still make insulin. If the patient does require some insulin, it's important that their daily insulin intake is less than 40 units. As I mentioned to you, these drugs should never be used with type 1 diabetes or with secondary diabetes like gestational diabetes or diabetes that was caused by an onset of, is a side effect of another drug. All right, don't treat those patients with these compounds. They can be used in combination with some of the other drugs that we'll talk about, the bioguanides or the glitazones, mainly because they have a different mechanism of action that we will discuss. So, what are the side effects of these compounds. For the first generation, the toxicity was relatively low. So that's why I mentioned today, even today, they still do work. But they can, in some cases, cause hypoglycemia, mainly because of overdose. Occasionally, you can see some hepatic toxicity, again, if severe overdose. Some people have hematological reactions or allergic reactions, and you do get some weight gain. The secondary drugs, they got rid of a large amount of these side effects, but they do still cause some very rare cases in terms of overdose, some hypoglycemia. So, what is hypoglycemia? Hypoglycemia is the main complication or side effect of insulin treatment, and it also occurs in patients taking sulfonylureas because of what I just told you, the mechanism. Imagine if you take too much sulfonylurea and you completely block those potassium channels, and so you essentially are just flooding insulin out of those beta cells. You can then very quickly get hypoglycemia. Hypoglycemia is defined as a low blood glucose concentration. In general, children and adults are not usually symptomatic unless glucose falls below 2.2 millimoles per liter. What are some symptoms of hypoglycemia? You start to see initially, as you start to get lower, you get counter-regulatory responses, so catecholamines and glucagon that drop. You start to see cognitive disturbances, heart changes, and eventually the patient will go into a coma as it gets lower and lower. So it's a very, very, very serious situation, and it needs acute attention for hypoglycemic patients. Normally it leads to the suppression of insulin secretion and an increase in catecholamine secretion, which obviously is where the heart side of things come from. And it causes stimulation of glucagon, cortisol, and growth hormone, all of those things to release the regulatory. Those are the hormones that we talked about that counter the insulin levels. And the idea, and these are all autonomic, so it happens right away. And the idea is to restore blood glucose levels and to alert the individual that it's time to eat something. Say, hey, get some sugar in me, get some glucose in me, right? The catecholamine surge accounts for the signs and symptoms most commonly seen in hypoglycemic patients, which is sweating, shaking, pins and needles in lips and tongue, anxiety, palpitations, feeling weak, slurred speech, double vision, hunger, and nauseated. I remember when I was doing my PhD, my graduate advisor would often become hypoglycemic, and well, not often, but a couple times a year, and several times we had to call the hospital, and he was taking an ambulance because it was a very, very serious situation. He was type 1 diabetic. So, what are symptoms for hypoglycemia in terms of things that you can quickly recognize, and why does it become obviously so severe? Because eventually the glucose supply to the brain will decrease, and the symptoms of cognitive impairment can start to, the patient can appear confused, all of a sudden detached, change in behavior, and then they can have convulsions, go unconscious, and then eventually go into a coma. So typically, though, when the patients, so this is the biggest risk, obviously, is that when someone is driving a car and becomes hyperglycemic, they obviously are a risk to themselves and to society. So hypoglycemia caused by an oral anti-diabetic drug should immediately be admitted to the hospital because of the hypocemic effects of the drug can last for long hours. Remember, I told you the sulfonylureas, an overdose of those will drive up insulin release, and those drugs last up to 24 hours. If you remember that I mentioned. So if the hypoglycemia is not due to just misregulation of insulin, but instead to the drugs that they were given, it's important you get them into the hospital because they may be in a coma for a serious amount of time and period. Now, it's important in the nausea. So I mentioned here the nausea aspect. The patients typically are not vomiting; they just have severe nausea. What are some of the responses caused by? So the sweating, pounding heart, shaking, trembling, hunger, anxious, and tingling all come from the adrenaline receptor responses, and that's the release of the adrenal compounds. And the lack of glucose is what causes the confusion, drowsiness, weakness, and odd behavior and speech difficulty. And then the other non-specific are, and sort of not, you can't pin them down to one hormone per se, are the nausea, headache, and the tiredness. Visually, the patients might start to shake or have heart palpitations or to sweat, or they become dizzy or anxious. All of a sudden, they could be hungry because the body's trying to tell them to eat. Blurry vision, very weak, or a headache, or become extremely irritable. So how do you manage hypoglycemia? At first, you give initial glucose by mouth, either in liquid form or as sugar. Roughly 10 grams of glucose, just basically a teaspoon or so. If you need and you can give kind of a purified glucose version, so sort of fast-acting dextrose gel. It can be squirted onto the gums of someone who for example, has trouble swallowing. Maybe you're not able to get a spoon or a lump of sugar in them. But the bottom line is you want very short-acting carbohydrates that immediately will have an effect on the patient. And then if you don't see immediate changes in, say, minutes, you can repeat this in the next 10 or 15 minutes. So after the initial treatment, try to give them some food, providing them, again, with some sort of sustained carbohydrates, noodles or a sandwich, fruit, milk, or some biscuits or cookies. Or, obviously, if it's time to eat, have them go ahead and eat. And this can prevent blood glucose concentrations from falling again because you're providing them with some long-lasting carbohydrates. So, hypoglycemia, which causes the patient to go into unconsciousness or a coma, is an absolute emergency, and it's essential that you get them to the hospital, or obviously if they're already they've got an ambulance nearby, you inject in them glucagon, which will increase plasma glucose concentrations by mobilizing what glycogen is stored in the liver. These injections are typically intramuscular, and in some cases, please also follow it up by injection. You follow up with a glucagon injection again if you can't get sugar into their mouth because they're unconscious. So you can't get them to swallow anything, or even you can't even put those little glucose pellets in their mouth because they're They're not going to swallow anything. It won't get you anywhere. So it's immediate. Very important you quickly give them the glucagon injection to try and stabilize and release that stored glycogen. Finally, if the injected glucagon doesn't work, give them glucose by IV. And this obviously is probably your last hope for getting there, stabilizing them. Now, due to the mechanism of action of the sulfonylureas, there are drugs that can prolong or potentiate the effect, and then obviously this is good, but it can, in too much again, will cause an increased risk of going into hypoglycemia. So the drugs that can do this are acetylsalicylic acid or aspirin, sulfonamides, and allopurinols, all of which can potentiate the risk of hypoglycemia. And then drugs that counterbalance and worsen the glucose tolerance are things that you might think make sense, and that would be corticosteroids, obviously because they're going to counterbalance insulin, oral contraceptives, which are some of the hormones that we'll talk about, but that have a feedback loop, again, that impact on GH and impact, and again, counterbalance insulin's effects, isoniazides, and thyroid hormones. Thyroid hormones, again, obviously impacting GH. Okay, so that is the sulfonylureas, and now let's try to cover the glionides. Meglinotides are prandial glucose regulators. Okay, so remember, our glucose levels change after we intake food, and that is another area you can try to target to impact on insulin levels and glucose. So remember, we talked about inhibiting these ATP-sensitive potassium channels on the beta cells. Well, these two meglinotides, ropanaglide and naglitide, they do the same thing, but on a different binding site than the sulfonylureas, okay? And that is in part why they have slightly higher potency, because they're binding in a way in a slightly higher affinity, and even though they perhaps have a higher off rate. Both of these compounds are rapid onset, short acting, and they are less effective than the sulfonylureas as a monotherapy because they come off faster, but they can be useful for sort of rapid, short-acting treatment. Again, the idea is to inhibit that channel in a way that it opens, you artificially depolarize the membrane and drive that calcium intake. Again, these are combination drugs that can be used with metformin for improved blood glucose control. So they sort of fast-acting, small changes, but enough to be effective in terms of modulating glucose levels. Both of them are taken before meals. If you miss a meal, you miss a dose, okay? So these are only to be taken right before one eats, and that is in part due to, again, the short-acting mechanism that they work with. What are the side effects of these drugs? Typically, the patient will have weight gain, and again, similar to the sulfonylureas, you can get hypoglycemia, but because they're short-acting, they're not as sensitive to the doses as sulfonylureas. you're less likely to see massive insulin level rise because these compounds come off the channel. They don't stay on there forever, as long as the sulfonylureas. Remember, the sulfonylureas is up to a day, and these are going to be more like an hour. Okay, what about these bioguanides? These bioguanides, they are different from the sulfonylureas and the megalinotides, both chemically and importantly in their mechanism of action. Now, what does that mainly mean to us? It means that typically it facilitates dual drug use if we need, because the mechanism of action is different, right? You can't really use the megalinotides and the sulfonylureas together because they're both binding to the same target, whereas these bioguanides have a separate drug target. Importantly, however, bioguanides do not stimulate insulin release, and thus the advantage is, and why they're quite popular, is they don't cause hypoglycemia. You don't have that risk of overdose that you do with the sulfonylureas, and that's mainly one of the major reasons people have moved away, tried to avoid sulfonylureas, and metformin typically is one of the first lines of treatment these days. So the bioguanides appear to increase glucose uptake in the muscle and decrease glucose production by the liver. So they have multiple targets in a similar way to insulin. So they target the intestine, they target the liver, and they target the skeletal muscle. Within the intestine, they're going to drive up anaerobic glucose metabolism. Within the liver, they're going to drive down gluconeogenesis and drive down glycogenolysis and increase fatty acid oxidation. All of these things will decrease hyperglycemia. In the muscle, they drive up insulin-mediated glucose uptake, so they make the little bit of insulin that is around more effective, and they drive up glycogenesis, and they drive up fatty acid oxidation. They suppress hepatic glucose production through gluconeogenesis, and it's thought that one of their mechanisms of action is to bind and activate an AMP-activated protein kinase. And this is an enzyme importantly involved in insulin signaling. So it facilitates and increases expression of that nuclear transcription factor SHP, which in turn inhibits the expression of hepatic gluconeogenesis genes, including that phosphoenol pyruvate carboxy kinase and that glucose 6-phosphate. Remember, these were important targets in the metabolic side of things in the liver. So these compounds act by targeting those intracellular aspects that we've talked about that were downstream of insulin receptor. Effectively, what this does is increase the insulin sensitivity, possibly through improved insulin binding to insulin receptors, but most likely by causing hyper signaling downstream of the receptor. What we see peripherally is we see enhanced peripheral glucose uptake. We see improved insulin binding to the receptors. We see increased GLUT4 translocation through that AMP kinase. And we see heart muscle metabolic changes via p38 MAP kinases and PKC dependent mechanisms that are also independent of AMP kinase. Importantly, it also increases fatty acid oxidation by decreasing insulin-induced suppression of fatty acid oxidation. And finally, within the gut, remember it targeted the GI tract, we see a decreased glucose absorption from the GI tract. Importantly, from a pharmacology, drug delivery, medicinal chemistry standpoint, and obviously from a doctor's standpoint, it is orally active metformin, so it makes it very convenient to deliver, no injections needed. It doesn't bind plasma proteins, right, which is a nice touch at some level. So you have an excreted unchanged in the urine with a half-life of 1 to 4.5 hours. So you can easily monitor how much a patient is taking up because it's coming out unchanged. And also means it's not being metabolized. It's often combined in a single pill with other anti-diabetic medications, which is also convenient. So you can give a patient just one pill, right? Because you'll have learned from some of your clinical practice folks, and later on you'll learn drug compliance is important, especially in older patients when they're taking 5, 6, 7 drugs. So the ability to package metformin in with other compounds for treatment is an important aspect. And some of these other compounds that you see in the same single pill with metformins are the glitazones, glipizide, sitagliptins, and the ripilinides that we'll talk about. Metformin is also used for a variety of other things, including polycystic ovary syndrome. It's actually also in clinical trial here at Queen Mary for the treatment of pituitary disorder discovered by one of the professors here at Queen Mary. So it's also been reported to be effective, metformin, in treating a neurological disease for children, which I'm blanking on right now, the member. Fragile X syndrome, apology. Now, what are some of the side effects and toxic effects of these bioguanides of metformin? Metformin can produce lactic acidosis in some rare cases, mostly in patients with a renal impairment. It can also cause some nausea, abdominal discomfort, some diarrhea, and provide a sort of metallic taste to the patients with slight increase in anorexia. You see a decrease in vitamin and folate absorption in patients that are having chronic metformin, probably related to a drop in changes in their metabolism. And if the patient taking metformin has a heart attack or septicemia, you've got to stop the metformin immediately because this can overwhelm their kidneys and cause renal dysfunction. So what are the small counterindications for metformin use? Hepatic disease, obviously, because you need the liver to clear it, and the impact on the liver function by metformin. And a past history of lactic acidosis, any cause, means the patient shouldn't be given metformin. And any cardiac failure, the patient should not be, again, given metformin. And finally, any chronic hypoxic lung disease, which could cause metabolic acidosis, is also a risk. I seem to recall, I thought I saw some studies on metformin and COVID-19, but I can't remember what the conclusion was for that. Maybe I'll try to find that and put it up, see if I can hunt it down. Anyways, well, that's all I've got for you. We'll take a stop here for the day. I don't want to overwhelm you with too many drugs and mechanisms of action because it can get confusing how they all work. And I'll try to summarize these two tomorrow just so we make it clear, because I want you. These are probably the two most common families of drugs, or the three we've covered today, sorry. So I want you to be clear on how they work and how you can use them together. So